would like to ask Sithombo to come up and tell us how we should be treating fragility fractures. Thank you.
Good afternoon, everybody. I was a little bit late coming this afternoon. In fact, I almost missed giving this talk altogether. So on the way here, I was quite nervous in terms of how much time the chairperson would give me. So I changed my talk a little bit and I put my conclusion first. So I start with the take-home message first. So in terms of treating these injuries, we have a responsibility to ensure that the elderly with osteoporosis fractures are adequately investigated, and importantly, that the underlying osteoporosis has been treated properly, and this will help to prevent further fractures. And the treatment of these injuries, like I said, goes beyond just the treatment of the fracture. You need to go and investigate and treat the osteoporosis. A multidisciplinary approach is crucial, and I'll show you which team members need to be involved. And you need to remember the 3 I's, which is to identify the patients with osteoporosis, investigate, and initiate treatment. And lastly, I'm going to talk briefly on a fairly new entity, which is the fragility fractures of the pelvis. So that's my take-home message, that you need to ensure that treatment is initiated during the first hospital stay. And if you're looking for a catchy slogan, that's the slogan, that you must capture the fracture before the patients go home. So if you remember nothing from this talk, just remember that take-home message, please. So I'll be talking briefly on the magnitude of the problem, the challenges facing us as orthopedic surgeons, and also facing the patients with osteoporosis. And I'll talk on the fracture liaison service, the principles of orthogeriatric co-management, and how we evaluate and optimize them preoperatively, what's available to us in terms of surgical intervention. And like I said, we'll talk briefly on fragility fractures of the pelvis. So just by way of definition, what is osteoporosis? It is a disease characterized by low bone mass and a structural deterioration of bone. So importantly, it is not a pathological entity. There's no infiltration of the bony tissue by abnormal tissue. It's just over the years, they lose structural integrity. And if you compare the neck of femur area in this X-ray on the right, there's fairly good bone density compared to the left one. And if you had to take 3D CT reconstructions, in a young patient with normal bone, you sort of expect the picture on the right, which has got quite good bony coverage everywhere. But in osteoporosis, you can see that the sacrum is virtually destroyed. I mean, those are all the holes that you find. So the areas commonly affected are going to, well, if you look at the iliac wings, again, there's no bone there. The lateral area of the sacrum and the neck of femurs are often the areas most commonly affected. So because of this low bone mass, there's a consequent increase in bone fragility and susceptibility to a fragility fracture. And a fragility fracture is defined as any fracture that is sustained from a fall from a standing height or less. Now, these patients will present in 2 ways. There will be the obvious patient who has osteoporosis that we somehow miss, but then there will be those ones who are not so obvious, where you need to dig a little bit deeper to uncover the underlying problem. So this is a 8-year-old patient that we saw. This was from 2008. So she came into casualty, complained of a painful left hip. X-rays taken, no obvious fracture there, and she was sent home. And came back a few weeks later, fell again, and now the fracture is obvious. And of course, we did what we do best, fix the fracture and send her home. Came back about 6 months later, has now fractured the other side. And again, we do what we always do, and we fix the fracture, well, in this case, replace the fracture, and send her home. Disappeared for about a year and came back 1 year later with an ankle fracture that was also fixed. And again, after this, she was sent home, no investigation, nothing, and came back now with the distal radius fracture. And again, this was also fixed. Now, the only time when the penny dropped was 4 years later, when she came back, fell again, and now she has a periprosthetic fracture on that very first fracture that she sustained. Now, this looks a little bit dramatic, but in reality, this is what happens, that patients come in and they are treated, but they're never investigated for osteoporosis. And with a DEXA scan, which clearly showed that she was osteoporotic, and only now that was her therapy commenced for osteoporosis. Then the other group of patients are the ones who are not so obvious. This is a 54-year-old male, appearing quite healthy. He was working in his yard, slipped and fell, and sustained an ankle fracture dislocation. And this was post-initial reduction before fixation. Again, 54-year-old, looking fairly healthy, your standard average middle-aged patient. And then he comes in 6 weeks later. And at this time, he was still using his boot and crutches. So he was trying to get out of bed at night. He didn't have his crutches on, and he was so nervous to put weight on the fractured ankle side that he missed his step and fell and sustained a neck of femur fracture. Now, this is an unusual pattern in a 54-year-old where there's the obvious valgus impaction type, but there's also a fracture line going down the neck, which is a little bit more vertical in terms of the Powell classification. The CT scan confirms the fracture extension into the neck. But this, again, it didn't make sense to me to have a 54-year-old who basically sustained a grainy fracture and he's got no medical history, he's fit and healthy. So I went back to him and, that's just his CT scan confirming just how soft his bone was. So I went back to him and I dug a little bit deeper in terms of his history. And it turns out that his mother died of a malignant melanoma, and that was about 10 years ago. And from that time to this day, he's been shade hopping. He just has not been out in the sun. He avoids the sun completely. Whenever he goes out, he puts hats on and umbrellas on. And so he did his vitamin D levels, and his level is 5. And normal has to be above 30. So he's obviously got vitamin D deficiency. And again, that's his DEXA scan in the lumbar spine confirming osteoporosis. So this is the kind of patient that you must also be on the lookout for in terms of investigating and managing osteoporosis. And this was his just intra-op pictures showing that the instability of the femoral fracture. Look, we can debate, I'm sure, for a long time in terms of the optimal treatment for that, but I chose to replace his hip. So some interesting facts about osteoporosis. It is a silent killer, and because of the increasingly aging population, it has reached epidemic proportions. 1 in 2 women and 1 in 5 men above the age of 50 will sustain an osteoporosis-related fracture. It is a little bit rarer in males, but if they sustain a neck of femur fracture, their outcome is worse than females. 20% only will have some kind of investigation and treatment for osteoporosis, and these are figures from about 5 years ago. The other 80% will not be treated and will not be investigated for osteoporosis. 30% will die in the first year. This is a fairly universal figure, and I think it was reproduced at Steve Biko Academic Hospital in terms of our local studies. 1 in 5 will have had a warning sign, which is a previous fracture. And commonly, it's a neck of humerus fracture or a distal radius fracture. And that is often the time that we need to intervene. So it's almost like a cry for help, like Professor Dunn called it. And 30% of them will not return to their house and live independently after they sustain a neck of femur fracture. And 20% will be on some kind of permanent assistive device for mobilization. And 20% will be back within 2 months into the hospital with another problem, whether it's a rib fracture or a pneumonia or DVT, but some other condition. So it really is it's not a problem that is isolated to the neck of femur fracture. It's got far-reaching implications and consequences for the patient. And this is just to highlight that this problem is not expected to get better. It's going to get worse in the next couple of years. And the number of people aged 80 plus is going to triple in the next 40 years, which of course will bring with it an increase in fragility fractures. And there are also economic implications from these injuries. And so if a patient has fractured one side of the hip, there is a 2 to 5-fold risk of them sustaining another fracture. But importantly, this happens if there has been no intervention for the underlying osteoporosis. So the challenges facing us as orthopedic surgeons is that, firstly, just purely from a technical point of view, they have abnormal bone, which is soft, so you need to have, to come up with better ways of fixing implants to bone. They present with multiple medical comorbidities, which are sometimes something that we can't control ourselves. And also the time is gone now where they're basically fixed and just banished back into the old age home. They're now becoming increasingly active, and they want to maintain their activity levels. So they need fixation devices that are going to allow them to, to continue their active lifestyles. And there is enough evidence out there to suggest that there's insufficient knowledge about osteoporosis by orthopedic surgeons. So in terms of principles of management, I think the whole buzzword now is the fracture liaison service. And this basically brings together a team under the umbrella of orthogeriatrics or geriatric orthopedics, but basically it's co-management by a multidisciplinary team. And most hospitals will have a physician who has a geriatric interest, or even a rheumatologist or endocrinologist. So their job is to, of course, optimize the patient before surgery and afterwards initiate therapy for osteoporosis. You've got an anesthetist as well who's involved intraoperatively, and the rehabilitation team, and this includes biokineticists and physiotherapists and occupational therapists, because basically what you want to do is to get them out of bed as soon as possible, but importantly identify any hazards in their homes in terms of falling risk, and also to strengthen their muscles to prevent sarcopenia and hence preventing further falls. And we use family physicians now to continue with the osteoporosis therapy once they've left the hospital. And social workers, just in terms of getting them, like I said, some of them never return to their home, and dietitians to optimize the diet and improve their protein levels. So it can take multiple forms in different hospitals, but essentially the core structure is the same, that it's one unit that is responsible for looking after these patients. So, and the orthopedic surgeon is key to this team. And the reason for that is that we are often the first people that are consulted about the patient. So if we do not ensure that the team approach is initiated, nobody else is going to do it. So the responsibility lies on us to ensure that all protocols are adhered to. And the aims of the multidisciplinary approach to these injuries are to shorten the hospital stay. You also lower complication rates by moving them and mobilizing them as soon as possible. Ultimately, you're going to lower readmission rates and improve the quality of life. And with that, of course, comes the reduction in mortality as well as preventing the second fracture. So we have a protocol in place, and we achieve all of this by basically prioritizing them in the emergency unit, that they mustn't spend much time in the trauma unit. They are flagged, they come in, they get their bloods, catheter, traction, Clexane, and up to the ward immediately. And we notify the physician as well to go and see them and prepare them for theater. Ideally, you want to operate within 24 hours, and you can stretch it to 48 hours if there's a comorbid condition that needs to be stabilized. And they go to high care post-op. But importantly, in terms of analgesic, we prefer non-sedating analgesic so they can get up and mobilize the following day. We've been doing mostly femoral nerve blocks now and catheters as opposed to IV morphine or IM morphine. And once they are mobile, then they get their DEXA scan testing. If it's not positive for osteoporosis, most of the time they still get bisphosphonates anyway, but often we give them calcium and vitamin D therapy if they have normal DEXA scan. So surgery should be as early as possible, like I said, And also, we tend to shy away from GA in favor of spinal anesthetics. And also, you basically want to fix them as soon as possible, prevent further blood loss, so minimally invasive techniques, and you must optimize your implants for the osteoporotic bone, blocking plates and stuff. And the elderly cannot cope with partial weight bearing, so whatever you do, they need to be able to take full weight immediately. We are part of a trial now. I mean, I spoke about the 24-hour time to surgery, but we're part of a hip trial called the Hip Attack, which is a multinational trial that is basically what we're looking at is if you were to take them to the theater within 6 hours as opposed to 24 hours, would that improve the outcome? And the thinking behind is that if you look at stroke and heart attacks, you know, your best time to intervene is within the first 6 hours. So if you intervene early, you improve the outcomes. So we're looking to see if the same goes for neck of femur fractures. So like I said, you need to, we use usually percutaneous implants to minimize blood loss and minimize theater time. Now the other challenge with these patients is the soft bone that they present with, and neck of femur fracture on the right treated with an IM device, but it's obviously cut out. I mean, there may be technical issues with that, but also there's the fact that, you know, the bone is quite soft, so it's very unforgiving in terms of misplacement. So to overcome this, like I said, we've got ingular stable constructs. You need to place your implants properly. But there's also a way to augment your fixation with some cement, and I'll show you an example. It's often with the PFNA blade, where once you've got the blade in, you can inject cement through the blade to improve the cutout strength of that. So the implant design is such that there are fenestrations within the leg screw, and once you've got the leg screw in place, then you're going to inject a dye. And these are the sequence of X-ray pictures with the guide wire in, and there's your pin that's now inside. You compress it. Now you connect the omnopaque dye. And what you want to see is dye coming out of here, but there should be no dye that goes into the joint, because if you do that, then you cannot inject cement. So once you're happy that the dye is not going into the joint, then you can start mixing. So it's a pre-packed mix of cement, and they'll give you multiple syringes to inject through the blade into the neck of femur. And that's the cement now going in, and that's the final result. So this is just there to improve the cutout strength of the bone. And like I said, a word of warning, so when you do this, try with your initial guide wire, do not penetrate the cartilage, because if you do, your dye is always going to penetrate that, and there's danger that cement is going to go through the joint. So if you breach the joint, then you cannot do cement augmentation. So post-operatively, we mobilize them, like I said, within day one, within the first day, and all of this is done to prevent all the complications of recumbency. And then lastly, I'm going to touch on fragility fractures of the pelvis, which is a fairly new entity, and also with the increasing number of osteoporosis-related injuries, we're starting to see these fractures a lot. They differ from the usual injuries that we see in young patients, in the sense that they are all low-energy injuries, and also their ligaments are intact. So the injuries are purely bony, unlike the young patients where there's bony and ligamentous structures, and it's the ligaments that cause instability. And also with most young patients, once they've sustained a fracture, you expect them to gradually get better and get more stable and heal. Whereas in the elderly, there's a subset of patients that present with a fairly benign-looking pelvis fracture, but over time it gradually gets more and more unstable. I'll show you some examples now. So this is the landmark article on these fractures from Paul Romans in Germany. So they're divided into 4 types, which is type 1, 2, 3, and 4. And type 1 is really just fractures which are involving the anterior lesion only. Anterior ring only. Type 2 fractures have a posterior lesion which is undisplaced. Type 3 have a posterior lesion which is displaced, and it may either be the sacrum alar wing, it may be the joint, or it may be the sacrum itself. And importantly, with these injuries, if you don't do a CT scan, you will miss most of the posterior injuries. And D type is where you've got unstable injuries at the back bilaterally. And like I said, so all of these are bony injuries. There's no associated ligamentous instability. So this is an example of a 90-plus patient who came in with a left inferior and superior pubic ramus fracture. And of course, we do what we always do. You just keep them in bed until they can mobilize, and you get them out. And she came back about 6 weeks later, and now she's starting to drift. She's not getting better. There's no recent trauma. She's just not getting better. And by about 3 months, she has almost an established non-union. And if you do a CT scan, if you look at the back, she's got an associated posterior lesion, which is almost always missed if you do AP pelvis only. If for any reason there's ongoing instability and you cannot see anything on CT scan, we can even do an MRI scan, and there's often some bone edema. And so about 3 months later, she progressed now to fracturing the other side and fracturing the neck of femur as well. And again, you can find them in younger patients. There's a patient that presented to us in January this year, came off a mountain bike, and she had a superior and inferior pubic ramus fracture. Again, treated non-operatively, and seen about six weeks later. Now the picture, instead of getting better, it's getting worse. In fact, you can now start seeing fractures on the other side as well. And again, so we continue a little bit with conservative care, ask her to reduce her activity levels, see her about 6 weeks later, and then now she's almost got established or establishing non-union, and there's an obvious fracture of the sacrum at the back. And so at this stage, this is probably the best time to intervene, and I know that if you don't intervene, I've had a similar case where I waited a little bit longer, and that's what happened to that patient, so that they get an established non-union, which is quite painful. So I took her into theater to fix her front ring and the back as well. And these are just the recommendations, that if they're type 1, then it's conservative. Type 2, you can still do percutaneous fixation. Type 3, which is unstable at the back, those will now require open reduction. And if it's type 4, you can even consider lumbosacral fixation because of the pelvis discontinuity. And the rule is that you should utilize all the strong bony columns that you have when you fix them. And the bony columns are basically these fossa screwed from the pubis right down to the ischial tuberosity. Must utilize the bone above the acetabulum, the supraacetabular area. That's all good bone for good fixation. So I'm not going to go through the take-home message again. I'll just leave you with this message that you should remember to capture the fracture. Thank you.
Thank you. I'm sure we could got a minute or two for one or two questions. I'll kick it off because, Sithombo, you mentioned the hip attack. But as you know, we've also been looking at other fractures that would have similar things, and there is some literature which says how much more likely in the world, not necessarily in South Africa, you are to get put onto osteoporosis management if you have a hip fracture compared to if, for example, you have a proximal humerus fracture or a wrist fracture, an upper limb fracture. So I think just the comment is don't ignore the fractures in the upper limb and concentrate only on the hip. But my question really to you is that this is obviously a swing away. You are advocating a swing away from what some of us would say in fracture surgery, stay off your bisphosphonates until the fracture is healed and then go back onto it. Can you comment on that?
Yeah. Look, it's a question that comes up often, and I think the rationale behind that question is that, for your fracture to unite, you need both the osteocytes and the osteoclasts to work, osteoblasts and osteoclasts to work in some form of homeostasis. And that now if you introduce bisphosphonates, you're going to remove your osteoclasts from the equation and hence negatively affect healing. It's a concern that has not been shown clinically, and there's certainly no delay in fracture healing if you start your bisphosphonates early. And also even if there was a limited delay in fracture healing, the benefits of starting therapy early far outweigh that potential delay because, like I said, once you do that, you're going to optimize the patient management and importantly, you can then prevent further fractures. Because most of the time, once the patients leave the hospital, they will not come back. I think there's very few patients who will see few doctors who will see these patients, at 6 weeks and stuff. And by the time they come back at 3 months, you've probably even forgotten that they are not on therapy. So the best time to start treatment is in that first hospital stay.
Okay, we have Mac.
Thanks for the lovely comment. One of the things which has come up with putting these patients on biphosphonate is atypical fracture, which is tending to throw away a number of orthopedic surgeons. Can you tell us your view on this?
Basically what atypical fractures are they're common in the proximal neck of femur, and they are, because the bone becomes so hard that it becomes brittle and then it fractures easily. They are often known as Fosa-Max fractures. So yes, it is a concern of long-term bisphosphonate therapy. So to overcome that risk of exposing patients to extended periods of bisphosphonates, there's something called a treatment holiday or treatment window. It's a treatment holiday. So they're on bisphosphonates for about 3 to 4 years, and then you stop the bisphosphonates at 3 to 4 years. And the effect is quite long-standing, that even in another 2 or 3 years, when you repeat the DEXA scan, if it's still normal, then you sort of keep them off the therapy until the DEXA scan starts showing signs of reducing, then you can recommence. So just remember to, in your plan, just build in that treatment holiday after about the 3rd year of treatment.
Sure.
Yeah, thank you very much for a very good lecture. Just one thing that you didn't touch on, I think we funnily enough have a opponent in the medical field. It's called the general surgeon and breast cancer. And in Gauteng, the women have great difficulty in believing that they've got to take appropriate treatment to counter osteoporosis, because they're all going to get breast cancers. And they forget about the 30% try. And I think we've got to, shall we say, be aware of the 5th column in our midst and do something about that as well. Thank you.
Thanks.
Okay, sorry, we can't see. There are no more pressing questions, but again, as I said, hopefully we'll have a few minutes at the end now still to talk about it. Can we have the next talk, please?